works for this, so I've got to use my phone, so it's a dodgy camera. I'm like, yours all central, mine's like different angle.
That's fine, Joanna. Thank you for that.
Oh, there we go.
Right. May I just let everyone know that the recording has started? Thank you. So it's 10 o'clock, and without any further delay, we will welcome our guest speaker, Sarah Clayton. My name is Dr. Jean Davis, and I have got the privilege of being ABPN chair. We have Fiona Smith on the call, ABPN fellow, who many of you will have been in contact with to join the webinar today. A very warm welcome to everyone on the call, and we will go over to Sarah now, our guest speaker, to introduce herself and to lay out the format of the webinar. Thank you, Sarah.
Thank you ever so much, Jean, and thank you to everybody at ABPN for inviting me to share some work with you today. So yes, my name is Sarah. I am what do you need to know about me? I have worked for just coming up 30 years with children with complex disability, and I started out 1998. Yeah, 97, 98, with 35 families in Mansfield looking at the way that they were introducing nighttime positioning with their children. And that just was life-changing for me. It became a bit of an addiction, and I'm happy to say that however many years on, I've not been able to kick that particular habit. I have done loads of work all over the world. I've worked at various different in various different settings. So I do a lot of case managed work. Most of my work is supporting NHS teams. I also am one of the clinical experts on an international platform called Clinical Excellence Online, which is a platform for paediatric practitioners who are looking at very, very specific kind of areas of care that are kind of highly specialised, and we do lots of coaching through that platform. So what I'm going to do, I'm a mum of 4, and my oldest, Abby, who I've just spent a weekend with, and Johanna and I was just saying, my daughter's middle name is Johanna. Very important that the spelling is correct. I completely get that. When Abby was 6, she was diagnosed with a metastatic malignant brain tumour, and she is now 24. She had a very extensive treatment on a clinical trial, and that has resulted in a complex brain injury and learning disability, as well as lots of other health. I know that I am in the right room for people who understand the long-term impact on a child's body of that sort of treatment. And she had a very significant stroke when she was 9. But I was doing this work long before Abby was poorly, and I'm always grateful for that, because it meant that I had an idea that this world existed. And not only did I know that the world existed, I knew that there was nothing but luck and time that was going to prevent me from needing support, either for myself or as a parent, or, there was nothing different about me as a parent compared with the parents that I work with. And I also had a really, really good network of practitioners who I could call on. And I'm really passionate about parent education. So what I want to share with you, and we're going to go through so quickly, just kind of the background really of what postural care is all about, and the potential role for nurses, because it's one of those things. I did a project with Birmingham City University and Andrea Page, and we were looking at student nurses and their experience of delivering postural care. And it was really quite tricky for them, because a lot of them had come in from a healthcare assistant role where they were delivering postural care, day after day, night after night. And then that changed when they became student nurses and then nurses. And there's lots and lots for us to unpick, but we're not going to get time to do it in an hour. So I'm going to share my screen with you. Hopefully, Jean, can you let me know that that's worked? Is that
Yep.
okay?
It
Yeah,
has,
we're all
yes,
good.
thank you.
Okay, so we're going to just belt through. I was also, as you, like, so PGC, so I was also a teacher for 5 years in Aston in Birmingham. So yeah, but teaching is something that I absolutely, I love my job. I love the kids I work with. I love the families I work with. I love the clinicians that I work with, and just sharing information that people then are able to use in their practice straight away, to me, is just phenomenal. I work with loads of different organisations. So I work at, this is just so you know how I pay my mortgage, and that I'm absolutely upfront. I own Simple Stuff Works. We supply equipment to the NHS and all over the place. I work with Goldsmith and Goldsmith with privately funded children and young people. I deliver lots of training, and I'm also one of the clinical experts at Clinical Excellence Online. But I have the best socks in the world, or did have when I was younger. So I grew up in a house. This is my lovely mum and dad. We lost my dad last year, and we didn't lose him. My dad died last year. All those euphemisms are quite tricky, aren't they, when you're talking about death and dying? He was just the most phenomenal man. He invented the world's first multi-adjustable armchair for people with complex disability. My mum calls herself a recovering physiotherapist. I've lived, breathed, and worked this stuff forever. But we're going to quickly belt through what postural care is about, the key components of what it is and what it isn't, suggest some practical strategies for nurses and families, think about where it could be really tricky, and then signpost to some really good resources that you'll be able to use, you know, immediately after this webinar. So GMFCS, so the Gross Motor Function Classification Scale. Children who face difficulty in managing their own body in terms of their own movement, we can put those children onto a scale which is really kind of simplifies the level of challenge that child faces. And postural care, usually we think about children at GMFCS 4 and 5, and it's the continuous support of children's bodies 24 hours a day to protect their body shape, to improve their comfort, and prevent secondary complications. So when I say we usually think about children at GMFCS 4 and 5, we often miss kids at GMFCS level 2 and level 3 who develop changes in their body shape, but who don't get access to the same equipment as the kids that come into these two groups. So straight away, when we think about definitions, it can be really hard because whenever we define something, we often then we unintentionally exclude. So we're always thinking about, does this child's body need support? Are they able to protect themselves from gravity, or do they need us to give them a hand? And the three places where we think about that is where a child sits, where they stand, but absolutely the one that is regularly missed is the way that kids lie. So sitting, standing, and lying. And the reason it's important is because we have secondary complications that are associated with this increased vulnerability. So the more likely that a child needs support to change position, the more likely it is that they will experience these secondary complications, such as hip dislocation. And this is shocking, isn't it? You know, more than 90% of kids at GMFCS level 5 will experience hip dislocation. And the impact of that is massive. It's massive on the family, it's huge on the child, and it also has very significant cost and service implications for our health services. So we think about hip dislocation, other things we might think about. We think about, oh, somebody's not on mute, I can hear you opening your crisps. So if we think about scoliosis, we can think about the impact on wheelchair services. Lots and lots of different places like touch on body shape. So what we're going to do very quickly, let's see if this works. If it doesn't work, we'll just belt through. But this is just an animation that you can get on YouTube. and it just talks about why. And Fiona or Jean, you'll have to let me know if the sound goes funny on this, but let's just try it. Stuff it, it's not going to work. It never works. Do you know? It doesn't matter. I'm going to send you a link to that particular animation. It's beautiful, and you will love it when you get to see it. So when we think about protecting body shape, it's not about aesthetics. I was once, someone once said to me about that they were challenged by the idea that I wanted everybody to look the same and that I had a very traditional idea of beauty. And I was like, well, no, I've got a really traditional idea of breathing, actually. And I've got a really traditional idea of how challenging it is to swallow your food if you are sitting in a position where your head position makes that really hard. It's nothing to do with beauty, and it's everything to do with form, a person's body shape, and the way that that little body can function. And we're talking basic function here. All right. So these are all areas that are impacted by, when a child's body becomes more and more complex, these are all areas that could well be impacted. So the key components: positioning during the day, sitting, standing, lying, and mobility aids. This area here tends to be the area alongside equipment and assistive devices and probably transition and movement. Those three are pretty well known. Okay, we are all awake and we can notice if a child has nothing to sit in. That makes sense. But the area that I'm particularly interested in, I'm interested in the way that kids lie during the daytime, and I'm really interested in the way that they lie at night. And the reason I'm interested in that is because when you tot up the hours that a child is lying down, kids spend 3 times longer in bed than they do in school over the course of a year. And if kids lie unsupported and they are unable to change their position, we effectively splint those kids. They grow at night. We're effectively training bodies into these asymmetric postures and structures that then have a huge impact here during the day. So that's the bit that I'm generally interested in. And in 2010, as it says here, changes in body shape are highly predictable. In 2010, I published a paper that, because one of the things we know is that the lying position, because kids are in those positions for so long, those positions have a direct impact on the shape of that child's body as they grow. So if you look at a child at 2, then you will see the child at 15. I do loads of work with adults. About 30% of my work is with adults, and I'll show you the adult. From the child at 2, I'll show you the adult. It's highly predictable, and you can learn these patterns in the same way as you can learn, kind of symptoms of a particular illness. And you can look at things to watch out for in a child where you're nervous about, say, my daughter, and about the impact of her brain tumor in terms of, her function. So we can use these highly predictable patterns, and we can spot who are the kids that we need to hold on to and protect so that they don't go where we know they will go if we don't do something about it. So we think about assessment, and we can measure body symmetry. We measure, it's objectively measurable. We measure symmetry of movement, and we measure symmetry of structure. So we assess and we measure. We provide equipment. We support families to implement that equipment, and then we review. So if you've provided medication, if you've conducted an assessment and you've provided medication, the person is taking that medication as directed, you review and it's not working, then you come back to here and you think, what are we doing? What's going on? Is it being taken as it was directed? Is it the right medication? And it's exactly the same for postural care. But unfortunately, it's not as well You see, what do you say? It's such a, because changes in body shape and the development of asymmetry happens slowly and over time, it's really hard to pin down who is responsible for this child's body shape. And we'll talk a little bit more about that later and the challenge that provides for families. So one of the really common patterns, and this I'm only going to quickly go through this because we're kind of condensing, you know, a good couple of weeks worth of work into one session. But I just want to help you to see how we can learn a pattern, identify a pattern, and then help us. It just helps us to work out what we do next. So one of the most common things that we see in kids with complex disabilities is that they follow a wind sweeping pattern of distortion. And wind sweeping happens in all unsupported lying positions. So it happens in supine, which means on your back. It happens in side lying, and it happens in prone. But just for the sake of today, we'll just look at supine. So if a child's legs, and what we support families to ask the question, do my child's legs fall to, are they drawn to, are they forced to one side or the other? And if the child's legs fall to, forced to, drawn to the left, we tend to see a clockwise pattern of rotation in the chest, and the pelvis goes in the opposite direction. And if they're windswept right, the legs fall to, drawn to, forced to the right, the pelvis goes in the opposite direction, and the chest follows the legs. So we can start to learn general rules, and we can start to look at children and be saying, right, I need to be thinking about you. So all of these young people, children, young people, they're all windswept to their right. Their chest, when we talk to families about chest structure, we talk about the chest like a tower. So if I go back here, if you imagine a typical child, their tower, which is, it's called the sternospinal line, and it's an imaginary line that runs through the sternum and the spine. We don't have to go down all that jargon route. It's just the tower. So what we need to think about is that to protect that child's chest and spine, the tower needs to be upright. If the tower is falling over, we end up with rotational distortion. So here, if you were to imagine the tower, and if you took a pen and you were to put your pen through the sternum, through the spine, what you can imagine is that line, that sternospinal line, the tower, is falling over towards the child's right arm. And we can start to say, what am I looking for? I'm looking for the position of the sternum in relation to the lateral border. So I know which photographs to take when I'm talking to a therapist, when I'm saying, look, I'm worried that this child is beginning to rotate. All of these people are following exactly the same pattern of distortion, but this 3-year-old is far easier to support than this 30-year-old. So the earlier we can get in, both to identify children, not to wait until we've got bony changes, but to identify the children that are at risk, to think about sitting, standing and lying, the better. Because at the moment, we are generally a bit late to the party. And what we can do then is we can start saying, right, we are late. We can see that the tower is falling over to this young man's left arm. So if you think about a screwdriver, a screw and a screwdriver, here we've got the chest rotating this way. So our therapeutic intervention is to bring the chest around in the opposite direction. And the rule is, and we think about typical children, sternum central. So this little man's sternum is not central. So we block this side, we roll him until his sternum is central, and then we block underneath here. And when we do that, it's in this rib flare here. So before we do this, we know this rib flare here is going to make itself absolutely like, here I am. And if we don't prepare families for this, then what we're doing looks crazy and terrifying. So we need to, because the patterns are so predictable, the way that these little bodies respond is so predictable, it means that we can anticipate and we can prepare families for what it is that we're looking to do. And then the really exciting stuff happens, because if you do this, remember, three times longer in bed than they're in school. So if we do this night after night after night after night, we can put in a therapeutic force that positively changes body shape. We are wholly accepting of deterioration in body shape. So why, when we think about improving body shape, should we not be just as accepting? Okay, if we accept change in one direction, we need our minds open to the idea that we can influence change in the other direction. And here, this young man is 25 years old. There's 3 months work here, night after night after night. And it was an absolute unmitigated disaster. It was great for his breathing and for his digestion and his comfort and his pressure care. But because his wheelchair was a custom mold, he had nowhere to sit. And because the wheelchair service, he was not due for a review for a certain amount of time, his family faced a huge battle to get his seating adjusted to his new body shape. So we'll come back and we'll think about the barriers in a minute, but it's a really common one that the services that look at seating are not the same services that look at lying. And that's a problem. We can think about hip dislocation. The rule is, if the knee crosses the midline, you will tend to see posterior dislocation at the hip. And if the knee moves away from the midline, you will tend to see anterior dislocation of the hip. Why are we allowing the knee to fall across the midline or to fall away from the midline when it is that predictable? When a horseshoe pillow may well be enough to protect these soft, unbelievably soft structures as kids grow. So I just want you to just have a quick, this is Izzy, and Izzy is the most stunning young woman. Every morning, without fail, I have a WhatsApp from Izzy to let me know how her night was the night before. And every day I send her gifts and all sorts of stuff. Izzy doesn't use words and she doesn't type, but she knows her way around an emoji. So every morning she will let me know how she's got on, and I can share that with you. So think about the wind sweeping. Legs full to, drawn to, forced to one side or the other, to her left. Think about the tower. Izzy's tower is falling over towards her left arm. And look at her seating. So the way you lie is the way you sit. So if you don't get this bit right, this bit becomes more and more and more difficult. You know, it's just fundamentals. It's such a fundamental aspect of a child's care as to be. It's one of those things that's so obvious. But it's the assumption is that somebody else has got this. Somebody else must be doing this. And yet we see kids fall through gaps all the time. And when you know the patterns, I went to Paris, I took Abby to Paris last year. When you know the patterns of distortion, you can apply them anywhere. You can apply them in the Louvre to this stunning, what is she? Sculpture. You can look and you can say, what will happen if I leave you in this position for thousands of hours? You can apply all of the force, all of the theory to any body, any age, any diagnosis. You can apply the theory. And that gives you, it tells you what direction that person is going in. It tells you what's likely to happen in the future. It tells you the forces that you need to be putting in. It's all there. So things that we can do as practical strategies. The first thing is to find out if you're concerned about a child whose body shape is changing, then the first thing to do is work out where are they? Where do they spend their time in the 24-hour period? Are there any gaps in their support where we are leaving them to hold their own body, knowing that they can't hold their own body and they can't change position in the same way as we would? So are there any gaps? Are there any concerns about seating that doesn't seem to fit. Yes, he's got a wheelchair, but he's always sliding forward in it. You know, that number one, like kind of red flag, where there's something very wrong, is a kid sliding in their chair. And yet lots of people don't know that that's an urgent thing that needs to be thought about. So first of all, where are these kids spending their time? And then we start getting into the detail. And this tool was developed for nurses. It was trialed with learning disability nurses, and it was launched at RCN Congress a couple of years ago. And this is a referral tool to help nurses. I use it with families all the time because it pulls things together in a way that lots of families struggle, because there are so many different services involved. They struggle to put it all in one place. So it's basically looking at what are the challenges that this child faces in terms of their postural care. What are the other health complications that might affect the way that you would be positioning that child? The Mansfield checklist, which I wrote, which was published back in 2000, which is an identification tool. What's happening in 24 hours? And then this part here is starting to nail down what's the equipment, what's the issue with that equipment, is it missing, does it not fit, you know, all those things. And then who is responsible for that, which professionals, which practitioner, and then thinking about what do we need to do about that. So a way to just pull things together. Now, usually it's physios and OTs who will be prescribing either the sitting, the standing, or the lying equipment. And it's absolutely essential that they are so skilled with this stuff, helping them to do their job with really high quality referrals that come in and help them to see why you're concerned, why the family's concerned, and give them a heads up as to where this young person needs to go in terms of their no doubt enormous caseload is really helpful. Cake is also helpful. The other thing that you can do is you can use photographs to help you describe what you're seeing. And these are the 3 photographs that I ask every family that I work with to take for me. I want to know the young person's habitual lying position. What is there? As soon as a parent can say, when you say to them, can you just describe how she sleeps for me? And they say, yeah, absolutely. On her left side, you know, this arm's here, that leg's there, bang. You know straight away that this is something that you need to look at. If they say, no, absolutely not, sometimes she's here, sometimes she's there, sometimes she's, you know, then unlikely that they need me. The only case where that's a little bit of a like an amber, if you like, is when you have a child who has changes in their body shape, but they have lots and lots of movement, because that takes a bit more unpicking. There will be something in their lying. It just takes a little bit more to work out where it is. The next thing we look at, there is a therapist called Sharon Sutherland, who is a legend, absolute international legend when it comes to seating. And she talks about the life box. So if you were to lay a little bit of hair ribbon across this young woman's ASIS either side, her ASISs, those 2 bony bits at the front of her pelvis, and then another piece of hair ribbon across here at her lower ribs, what you'd find is that there were beautiful parallel lines. And that life box, what we're looking at there is typical symmetry. If we get a pinching on one side or the other, that's cause for concern. Or if a child's life box is beautiful when they're lying, but when they come into sitting, it significantly changes, so they lose that, that's an indication there is something about the seating that isn't quite right. And then the last thing we look for is the costal margin. So we're looking here to see, are there any little telltale signs in the rib cage that are letting us know something is beginning to kick off for this young person? So where is their sternum, and what's the shape here of the rib cage? And those 3 together help you to be like, right, I've got an idea of where we're going. So another thing to think about is why is this important? Because when we talk with families about nighttime positioning, firstly, don't talk to families about nighttime positioning. Go right back and just think about supported lying. Because one of the things that we have done when my beautiful dad was not very well, he was asking a couple of days before he passed away, he was saying, have I made a difference? And I said, oh, Dad, you've made the most enormous difference, you know? And he said, I've got 2 regrets. And I said, what's that? And he said, one was I never punched so and so. So he's ex-army, 25 years in the army. He was like, I never did sort out. And I was like, no, like that's not a good thing, Dad. And he said, no, but the other thing was, he said, I should never have called it a sleep system. And he said, because I set families up to fail. And he's right in that the term sleep system brings about connotations of nighttime, of that you've got to sleep in this thing, that it's got something to do with sleep. And actually, it's more about supported lying, isn't it? And if we want families to succeed in nighttime positioning, then we have got to give them a head start, and we've got to do a whole pile of work with them in terms of their daytime supported lying, so that when we start to think about nighttime, we already know a huge amount of information about that child, about the risks of certain positions with that child, all of those things. The child is used to, this is the way that I'm supported when I lie down. And the other thing we need to do is we need to think about how important it is to make the link between lying and sitting. So if these are your 3 playing cards, and this is the winning hand, being able to go to the football, being able to go to school and sit comfortably, being able to breathe, being able to eat your food and potentially have it go through your system and be eliminated without causing you pain and distress, which hand do you play? You do not play this one. You do not play this one. This is the one that's going to give you this. And it sounds dead simple, but it is really complicated and hard work. And we link wherever we can, we link the what we're asking of families in terms of supported lying, we link it to the F words, because it's the F words that make life worth living, isn't it? It's having a body structure and function that allows you to remain as healthy as possible, so that you can take part in activities you enjoy alongside your friends and family. You know, all of those things are the things that really motivate families. And then just to quickly show you, this is a young man, Taylor. Now, going back to what we talked about GMFCS 4 and 5, Taylor would come nowhere near working with me. Taylor was supported by a charity we were introduced a couple of years ago. And Taylor had meningitis as a baby. Now, his lying position is not because he can't get out of the position. It's because he doesn't have legs to be supported so that he can lie in a neutral position on his back. He has to be in this position, the one we see on the left here. This is my lovely daughter here. And this is Taylor. So this is just showing you the equipment that we used. So it's not complicated stuff. The key thing is that we need to think about immersion and children lying in their support and not on a mattress. And then it needs to hold the person if they are unable to hold themselves. And then sometimes we support the support. So this horseshoe pillow here, everything goes underneath a big stretchy sheet. And this horseshoe pillow here is being supported by equipment. So and pillows just, you know, I wish pillows did cut it. If pillows worked, then crack on, go for it. You wouldn't see anywhere near the distortion that you have, because families are doing this stuff instinctively. They are trying really hard to support their children, but without equipment that's designed for the job, and also without that ongoing support of where do we need that equipment, you know, they're on a bit of a hide into nothing. So this is just, let's see if this does play. Hopefully it will. This is in Taylor's WhatsApp group, and this is the first night that he used his equipment.
I've just got into bed now, and I'm all snuggly.
Which is what we like. So comfort, the top priority is comfort. And then the second and third priorities are comfort and comfort. If kids are uncomfortable, like nobody goes to work to make kids uncomfortable. So we need to be thinking about there's not the idea of no pain, no gain has no place in postural care. It is absolutely going to a child and supporting them where they're at so that they are able to relax, rest, whether that's daytime or nighttime. And then if we get a bit more ambitious with regards to the therapeutic strategy that we're trying to put in, then that will come later to having them trust that what you're asking of them is not going to hurt them. And then this is after the first night.
It was a different sleep, but amazing.
See, WhatsApp groups. You have to have a WhatsApp. Everybody deserves a WhatsApp group with Taylor. So this is just to quickly share with you the reason that I was involved with Taylor is because he was getting pressure injuries when he was using his, a number of different reasons, but one of the reasons was around pressure injury. His centre of gravity is so far forward. When you think about a child in prone lying, so lying on their tummy, tends to be kids who struggle to know where they are in space. So when we ask them to come out of that prone position, we need to think very carefully about the use of weight. Not necessarily a weighted blanket before everybody has a moment, but so there are lots of different things that we need to think about for the needs of different children, but we can learn those needs. And when we get him on his back and we put his center of gravity back, then we can see how we can, do you see how this function that he is desperate to maintain, the function is dependent on his form. And if we can support him not to spend thousands of hours in a destructive position, it has a massive impact during the day. And there are 6 weeks between these two photographs. Okay. No medication, no surgical intervention, simply a change of habit through the nighttime, plus support, physical and kind of emotional and kind of coaching and cheerleading and all of that sort of stuff for the family. So where can it, if it's so easy and if it's such a brilliant thing, where is it that people will struggle? So the number of children that I guarantee you that by the end of today, I will have met at least one more child who is facing many hours in equipment that doesn't fit, because we have a real problem, okay, with provision of seating, and it's not the practitioners that work in these services. We're going to talk a little bit about the complexity of the way it is all organised. There is something fundamentally amiss where children, and I'm thinking about children who are the most vulnerable children in terms of their ability to communicate pain and distress, their ability to advocate for themselves, their family's ability to advocate for themselves, because they are facing some of, kind of, when we look at the challenges these families face, it's not on them to advocate this technical stuff, and yet we see kids in chairs that don't fit. In the last couple of months, I've supported a child that is sitting in a molded chair that belongs to a child who has passed away, because in the school there is no other seating for that child. I've supported kids who are just, it's mind blowing that we are struggling with this at the minute. So there are lots and lots of different people that are involved. So it may be, and we're thinking about seating, standing, lying. Okay, 3 fundamental areas: seating, wheelchair and alternative seating; standing, potentially a standing frame, although not all children stand, especially as they get older; and lying, so supported lying. And these are all the different people that might be involved in that. So those are your health services. It may be that social care are involved. It may be that education is involved. It will be that there are equipment providers involved. They also have family carers. This whole thing needs to be funded and commissioned. There are then voluntary and advocacy organisations who may be involved in supporting families, kind of in the discussions that they're having. Then there are other teams. Don't even, before you even begin on transition. So kids are falling through the gaps, and they're falling through gaps that mean that we've got some really horrendous outcomes for some of the most vulnerable children. And the numbers of children who, like, I think the landscape that I work in now and that many of you work in has changed dramatically over the last 30 years in terms of the numbers of children and the complexity, the medical complexity of these kids. Yeah, it's huge. So we could think about risk registers. If we know that all of these things are a risk to these complex kids, we know that the likelihood, let's say hip dislocation, because we looked at that, the kind of incidence of that, the likelihood is high, the impact is severe. We think about those mitigating actions, we think about who is involved, and we think about how often we need to be working on this. And then we do everything we can to mitigate those risks. We keep coming back to the systems were never designed for the kids with the complexity that they have right now. We are still looking at people going out in vans with pieces of equipment to come and try it with a child and waiting 3 months and all of these sorts of things. So there's a lot to be done with regards to really looking at this system. And then we know that there are very, as well as the patterns of distortion being predictable, we also know that the journey for the family is also highly predictable. So we can think about where are the key opportunities that we have to get involved with regards to looking at a child's 24-hour postural care, and where are these transitions. Whenever I see transition, I think like whole. There's a hole here, because there's moving from one potentially group of people and setting to another. Whilst that might be an opportunity, it's also a risk for these kids. And then, there are so many, that's kind of from a service point of view. And then when we think right down to that individual child, there are also a whole load of other places where it can be very difficult for people to get this right, which is why they need so much support. And yet very often families face like a dump and run with regards to the equipment, because that clinician is shifting on to the next child on their caseload. So it's not because, as I say, it's not because people don't want to get this right. It's because clinicians face huge challenges in getting this right. So other resources, you've got Clinical Excellence Online. This is looking at, so these are all kind of internationally recognised experts in their different areas. So Dawn does bladder and bowel, Sharon looking at posture and mobility, myself looking at night positioning, lots and lots of different stuff here. Mary Massery. If anybody doesn't know Mary Massery, if you're interested in breathing, which I imagine a lot of you are quite keen on the kids that you support breathing, Mary Massery is a huge person to take a look at. And then from a nursing point of view, so I have a chapter in each of these. This one in particular I like because it's a double page spread, which if you're a student nurse, you have so much to kind of get on top of. So it is a double page spread, for example, on epilepsy, a double page spread on postural care, a double page spread on whatever it is. And then these ones are more detailed. And there's all sorts of other resources. There is a wonderful podcast. If you're interested in parenting experiences for kids with complex disability, then the Skies Were Under podcast, I can't recommend it highly enough, mainly because I'm one of the co-hosts. And it's not for younger listeners. It has we got a parental advisory on there from one of the podcast hosts, which was interesting. But there's lots and lots and lots of stuff out there, and please get in touch. There's my contact details. But on a personal note, from a nursing point of view, so I'm 18 years in, just a genuinely massive personal thank you, because I've met paediatric nurses and nurses who support adults now that my daughter is 24, and you're just a world apart from every other human. Like, there is something about nurses that just, yeah, you're a fabulous, fabulous bunch. So yeah, so that's me. So, oh my life, there's lots and lots of things in the chat. So, is there anything in the chat? Does anybody want to unmute? I know that we've got 15 minutes, and it would be great to have a chat. There's so many resources and people out there doing this stuff. It's a really vibrant community of people, and I would love to see more nurses, because there's lots and lots of physios and OTs who are fabulous, but they could all do with like a sprinkling of nurses over the top.
Oh, thank you so much,
It's a pleasure.
Sarah. That was an absolutely mind-blowing presentation, and maybe that lots of us have nursed children and young people,
Yep.
been with their families, and sometimes we felt quite helpless about what is going on, you know, the problems that keep emerging, and this has been revelationary. So thank you so much. So we really would like to hear from our audience now, wouldn't we? Fiona,
Absolutely.
you want to come in?
Hi, yes, Sarah, I'd like to thank you sincerely for doing a second presentation for children's nurses. Unfortunately, a number of students had sent their apologies because they'd suddenly got a lecture that they got to attend this morning. But I have assured them that the slides and the recording will go onto our website in due course. I need to thank you specifically for highlighting all of the different organisations that perhaps a nurse needs to lobby and influence. And offline, I'll have a conversation with you about where we need to go in terms of influencing commissioners in particular.
Absolutely.
Thank you.
Yeah, no, my pleasure, Fiona. It's a really complex. I think one of the challenges that families face is that it feels like something quite straightforward, that we will be able to get a wheelchair that's comfortable and fits, that as the child grows will be changed and adapted. We stress out about when our kids are tiny and we're told in Clark's, you've got to come back in 6 weeks' time because their little feet are going to grow, and, you know, like, kind of woe betide the person that leaves at 7 weeks. And yet there's a school that I work in every half term. I work in this school it's the school that supported my daughter. She was in mainstream. They were amazing. So now, years and years on, they have a day of my time every half term. The average wait between the assessment and the provision of a wheelchair is 12 months in that school. So we know that kids are waiting. And yet, you know, and not waiting, it's not a benign wait. You know, it's the kids are harmed in that time, and yet the accountability isn't there, and the system is so complicated as to just be it's mind-blowing. Teresa, I see Teresa and Victoria that you've got your hands up. Do you want to unmute? Use the power of the unmute button.
Hi, thank you,
Hi.
Sarah and Dean, for the presentation, and condolences, Sarah, on your dad as well. I lost my dad there at the end of December, so I know it's difficult. So thank you for the talk. The thing would be that, how do you get compliance? Issues with compliance where the child is not accepting the sleep systems, or that family are kind of struggling it as well.
Yeah.
With the issue, and especially when there's lots of staff coming in, especially if it's a home package in place. Are the notes for this talk going to be put up for a reference? As an email, sent as an email to us.
Yeah, I think so. I think it comes out. Fiona or Jean will let me know if I'm wrong, but I think it all goes onto the website and you're able to access everything from there. It's what we did last time. But if we go back to your question, so one of the things that we think about is ways in which we are working co-productively with families. So if we approach, if we think about, so recently there was research around the impact of service provision on mental health of families, and it was looking at trauma, systems generated trauma in family carers, and you can find it on the Cerebra website, and it's a devastating read. And there's also work from Siobhan O'Dwyer, who is at Birmingham University, looking at levels of sort of suicidal ideation in families. So if we come at it with an idea that we know what's best, and that we will say what needs to be done, and then families need to do that thing. And if we come to it and then we think about the idea of compliance, that's something that just to sit back, have a glass of wine, have a think about, in terms of, is there a way that we can switch this narrative? Is there a way that we could be thinking about why is it that this family is struggling? And so the staff teams one is another question entirely. I am completely with you. But just for I think that's where I've learned over the years that if we come in at nighttime, I can promise you that the loneliest, hardest hours is between the hours of midnight and 3 a.m, where there is nobody that you can speak to as a parent. That's not the time that we need to be asking people to do something new. That's not the time that we need to be asking them to do something that's potentially they're worried about their child being unsafe. You know, this new position that we're going to put them into, and then you're going to go away and go to sleep. So I think it's about just a blank slate and a rethink about when is it that we think about supported lying, and the nighttime bit we don't come to, like home and nighttime we don't come to until right the very end. Does that make sense? And from a staff team point of view, it's interesting, isn't it? Because we've got lots of compulsory training around moving and handling. So we're very, very concerned about how we're going to take the child from A and put them to B, but there isn't anything statutory. There's no mandatory training about where we leave them. You know, it's not recorded. It's not, if we think when we did the work with Birmingham City University with their student nurses, what they talked about was the idea that, like, you know, everything else is recorded. The position the person in isn't recorded. And so it was challenging for them to for people to be worried about that, because nobody monitors it, nobody tracks it, you know, kind of all that sort of thing. Is that all right? I've gone round it. I've gone around a bit there, but it's a really, really good question, because it brings into really sharp focus the idea of co-production. So co-production is defined as an equal and reciprocal relationship between family and person who is accessing services and the service provider. So at no point does anybody get to call the other one names or say, you know, you're not doing as you're told, because it is a plan that's generated equally and reciprocally by those two people. And when families say, I can't do it, then we need to work out why that is. We say nighttime's important, and then we don't give people night care. You know, we say night positioning is really important, crack on and do it, as well as every other hour, you know, as well as the employment stuff, the sibling stuff. It's really hard, really tricky. Is that all right? Victoria, you've got your hand up. Victoria's.
Yes, hiya, thank you. Yeah, I hope you don't mind me asking this. I'm actually coming this from 2 points of view, really. I actually used to do this job in a special needs school, so I was a past management, like looking after the children, obviously putting them in the standing aids and things like that. Now, I actually lost my jobs through my own disability, and I'm actually a client now. Yeah, I'm actually a client now, and just with it's really, I'm just very passionate that you're teaching other people about it. I actually have carers now and things like that now, and like what you were saying about, when they leave at night, I have like 4 calls a day now. It's completely changed. My life's completely changed upside down.
Yeah.
But just like with the understanding side of it, I think it's good, like I might even tell my carers about Let's Talk and get them to have a little look at it as well. I think they, for that, might, like, I have my kneecaps come out of place and my hips come out of place quite a lot. So I'm just seeing it like from two. I obviously used to do this as a career, but then it's like, obviously I've turned upside down now, and I completely understand where. Sorry I don't mean to be bombarded or anything, I just find it very fascinating,
No, not at all. And I'm really, really grateful for you for sharing that, because again, it comes back. There's 2 things, isn't there? One is that again, it's luck and time that separates us as people who support people from needing that support. And we always need to have that in the back of our mind. Would this be good enough for my mom? Would it be good enough for me? Would it be good enough for my child? And that's massive, isn't it? And I think the other one, please do share this with your care team. There's also there's a YouTube channel. There's all sorts of stuff where you can get free resources for carers.
I've actually listened to you before. I've listened to you before, so I've actually.
Oh, and you came back.
You
came back, Victoria.
So I came back as well. But it's very interesting. Just to obviously give you a bit. It is like, and I think because it's hard for it's because I used to do it as a career as well. I find it hard to keep my mouth shut sometimes, because you don't want to belittle people. Do you know what? You don't want to belittle people. But at the end of the day, I think it's very important. Like you said, like they go home. I only have 4 calls a day. Once they go home at night, I can't move. I'm bed bound at the moment, so I can't move on my own. So I'm struggling with accessing stuff,
And Victoria, what you said there is again is like absolute gold in terms of, it's not about belittling people, is it? And it isn't about like today's presentation isn't about saying,
no, it's not.
No, and but it's not. But when we're sharing this information, it's not to say that there is blame. It's not to say that there is a and you should have known this. It's not that absolutely isn't it. It's about that it's a really highly specialist aspect of care that not necessarily everybody knows about that. So it's just about making sure that people have got it kind of in their minds. But thank you, Victoria.
I'm sorry, Michelle, I don't mean to go. I'll go on. Yeah, it's fine.
Sorry. Michelle. Hello, Michelle.
Hi. So I'm a new clinical lead for a provider delivering care for children in their own homes and at school. I was previously a children's commissioner as a designated clinical officer for SEND. So I'm really passionate about making sure that as a business we are optimising children's position, because I know as well that makes a massive difference into adulthood, and we should be protecting that, shouldn't we? Because we don't want to move the problem elsewhere. What I'm really interested in, though, is how, as a provider, when you are quite often stuck as just being the delivery of care, how we support our care staff in increasing their skills and understanding how to use those lovely tools that you shared earlier on in your presentation to optimise that care, because what we should be interested in is improving the outcomes for every contact 100%. That we have with kids, young people and adults. And I just wondered whether there is there any kind of like training that you provide for private providers that can support us to do that adequately and effectively, and to also give the tools of safety and quality. So when we're having the conversation with the OTs and the physios that come into the property and with the school practitioners, the TAs, where we're supporting care there, how do we do that safely and with compassion and the security that our knowledge and skills is actually there and in place?
So the short answer is that yes, I can help you do that.
That's brilliant, thank you.
That's the short answer. The short answer is yes. And I think there is a wider question there, isn't there? Because again, it comes down to this thing of who is holding the accountability for this child's body shape. And the answer is nobody. Because fundamentally nobody. So it's about how do we, as a group of people, so whether we're a commission provider, whether we are statutory service, whether we're a case managed team, how do we work together for me, one of the biggest things is that we can measure the impact of all of these different interventions on a child's body shape in terms of their symmetry of structure and their symmetry of movement. We've been able to do it since 1992, and yet so many children don't have that data in the same way as if we were thinking about whether a child is, if we thought about a child's weight, we would weigh them, and then we would work out where we are in the grand scheme of things. So for me, it's always coming back to what are the specific needs of this child, what are the risk factors, and then starting to map out where are the different agencies that are involved here, because and also mapping out the family involvement here, you know, because sometimes you can have a conversation, you think that everything's sorted with regards to, because you've been having the conversation with the parent, turns out grandma is turning up, you know, when you've left and saying, no, you don't need to do that, you know. So it's about how do we get as many people, those influential people involved, and start, you know, I think that's the answer, isn't it? Is at some point we have to start, and we have to start writing it down in the same way as we write everything else down in terms of accountability, in terms of what's the evidence base. The evidence base is there, the guidance is there. It's the actual implementation that people really struggle with. So I don't know if I've answered your question, Michelle.
You have, thank you. No, lovely. Thanks, Sarah.
But yes, we can help you on that. And tools wise, the other thing that I would say goes back a little bit to what Victoria said as well, is I don't know. So one of the things that I use a lot is AI. I use it as a parent a lot. And the reason that I do that is because, Victoria, when you said about the communication, one of the things that I do is I run through all of the communication for my daughter. I run it through Copilot, and I say, please take out any hint of aggression, any, you know, all of the things. Please make this as concise and clear as possible. And having those tools just can help everybody just to make sure that their communication is absolutely crystal clear. But yeah, it's a bit out there in the ether, isn't it? The postural care stuff. Yeah. For everyone.
Yeah. And it's almost like that, not wanting to step on the toes of the professionals that are detailing the care plan for that child. Yeah. But then if you've got practitioners in there going, actually, this isn't right, I don't know how to raise that, and then you've got that pushback, haven't you, around that challenge?
Yeah,
well, you're just a care provider, and culturally, we are, but we also have to make sure that every contact is valuable to that child.
Yeah, I did a piece of work. This is how long ago it was, but it was with following Winterbourne View. East Midlands Strategic Health Authority commissioned me to look at postural care as a safeguarding issue, and they were looking at it from the point of view not of families not doing it, you know, but they were looking at it from a service provision point of view. Where are the gaps? I would argue that so the little girl that I was supporting recently, who was sitting in a molded seat that belonged to somebody else, you know, that she's uncomfortable in, that she's not got a wheelchair she can sit in, she's in a buggy that then she's falling out of, so they've nowhere to put her. I think that's a safeguarding issue.
Definitely.
You know, and I but it's having the evidence base. It's the evidence base, the data, that it's pulling all of that together, so that we aren't just kind of it's not a woolly thing. It's not one person's opinion of a particular piece of equipment. This is, you know, it's like we talk, you know, the sliding point of view. Just really quickly, I know that we're going to go over, aren't we? We've already gone over 3 minutes over. Jean, you'll have to shut me up. But
right, we wouldn't dream of that, Sarah. I think the point you're making is about the lobbying. We've got to do that, haven't we? Please complete your point, Sarah.
All I was going to say is, like, so let's say sliding in a chair. Okay, if you when we talk to families about what happens at a seating assessment, and then very often we will be, you say, okay, you know, when you go to your seating assessment, your child or young person should come out of their chair, They should go onto a plinth. They should have all of their ranges of movement relative to seating taken, yeah, so that you know exactly what that little person's hip is able to do. You know, then once the hip is here, what happens with regards to the lower leg, all of that stuff should be done. And very often when you're talking about that, families are like, no, that's never done. No, we go from one chair into the other chair. There might, you know, like kind of, and so sliding, and the risk is, let's say that you have, there's your trunk to thigh angle, and most kids are made to sit at 90 degrees. The assumption is that they can get a trunk to thigh angle of 90 degrees. But if they can't, and if that work hasn't been done to understand what the limitations are, so there's their trunk, there's their thigh. If when you come to here, the pelvis starts to go, then that angle needs to be measured so that you know if you do that, you're going to make the child sit like that. Not because they have to open here. So sliding, when I said before about a red flag of sliding, if you can't do this, the only way that you can open that angle is to push yourself forward and open the angle. And kids are clever. Kids are clever. They will try to get themselves to open up. And there's the pattern of distortion, the 1 foot plate and the headdress breaking is an absolute classic of trying to open one side more than the other. And that's not but what we'll try to do is we'll try to stop the sliding. So kids end up sitting on non-slip stuff, or they end up with something between their legs. You get young men with things between their legs to stop them sliding, and all that's happening is that their genitals are pressed against because that angle hasn't been understood. So there's something about our postural literacy that's really important, and having an understanding of not what every solution is going to be, but knowing I need to ask for help when. If I see this, I know that's a red flag. And that's because we aren't talking about nurses prescribing here. You know, you're not doing the assessment, but to know. So, you know, we do a piece of work at the end of every training course, and it's called Call Me When. And it's, what do you wish, as a practitioner, what do you wish that every family knew? Call me when. Call me when his weight changes by whatever. Call me when, if you ever see him sliding. Call me when you see redness on his skin. Call me when, you know, that's the kind of stuff that we need to have within teams, that people know what it is they're looking for and where they go to in terms of that escalation. But yeah, there's a lot of work to do.
Thank you, Sarah.
Yeah,
so two phrases we can take away: call me when, and what is my postural literacy? Maybe we take those two phrases away with us. And I'm sure we would absolutely love to invite you back at some point, Sarah, if you would be willing to come and see us again and present more of this really valuable information to us.
Thanks,
so
Jane.
It remains for me to thank everyone who's joined us today, and especially to thank Sarah for such a wonderful presentation. Thank you. I'm going to stop the recording now. Okay.
Thank you.
Thank you, Jean. I've just put into the chat, and I've spelt it wrong, but I do webinars for Well Child for parents, and they're parent only, so you can't come to the live thing if you're a practitioner, but you can see the recording, just so it's a safe space for parent carers. There's one up that's around the patterns of distortion. There's another one that's about the terminology that's used in this area. And then the next one that will go up next month is about what to expect in an assessment. So those are probably quite helpful from a I need to know a bit, but I don't need to know like all of it. You know, it's about that advocacy and having some language and skills that can help you in that role. But I've called it a webiste instead of a website.